Well, thank you. I'm embarrassed to receive this after all who've done so much before me and who we've honored tonight. I think I've gotten away with it. I've been on faculty for about 8 years now. I still hope I can claim, but I don't think it's for much longer, I can claim to be a young doctor. The concern that I had when I started writing, of course, stems from your own experience. And my experience at the time when I first picked up a pen and was asked to write an article was when I was a resident in surgery. And so the natural question was how I might get good at this job, and it was part of my reflections. And it turned out that we were all at a moment we were asking how we all get good at what we do in medicine. What's sharpened in the last couple of years is that the question has become what exactly we want a doctor or a nurse to do next week that will make your care better, lower cost, safer, and simply more humane. It has been something that it's been quite unclear to us what the answer to that question might be. But I think the people who came before me have started to illuminate exactly what they were talking about. In a lot of ways, all I've done is tried to write about what folks like Paul Grundy, Patty Gabot, Helen Darling have been pushing for a long time and what they've been demonstrating for a long time. There are certain things we don't want doctors and nurses to do any differently. There was a time when healthcare was cheaper and totally ineffective. One of my favorite writers from medicine is Lewis Thomas, who was a physician and poet, former head of Memorial Sloan Kettering, and he wrote in his book, The Youngest Science, about what it was like being an intern at Boston City Hospital in 1937, the pre-penicillin era at that time. And what he pointed out was that there was very little that they did as doctors that seemed to make any difference for patients. If patients survived their diseases, it was because of the attentive care and humane support of the nurses, having a warm place to shelter, having some food and kindness. But the doctors didn't seem to do anything that mattered. That didn't prevent them from being frantically busy, though. They seemed to find plenty to do. And what they were doing was focusing on asking, does the patient have one of the few diagnoses that they could do something about? And there were a few. If you had a congestive heart failure, they could bleed a pint of blood by opening up an arm vein, give you oxygen by tent, and digitalis as a crude leaf preparation. If you had an early paralysis and they could ask very astute questions and figure out that you might actually have syphilis, they could give you a treatment for syphilitic paralysis that sometimes worked, but it was a combination of mercury and arsenic and might kill you in the process. There were a few operations that the doctors could do, but beyond that, not a lot more. In the time since then, in the 3/4 of a century, we have discovered an extraordinary range of ability. More than 6,000 different drugs, more than 4,000 medical and surgical procedures, capabilities to treat virtually every one of the more than 13,000 ways the human body can fail. And what is clear is that we can't handle it. It has exceeded our ability as doctors and nurses to just hold it in our heads and know what to do. And the sign of it comes out of folks who are here, who have run the data, have showed us the statistics, and they show that there is a wide bell curve in the ability that we have to produce good results, a wide gap between what the best and the worst achieve, and most of us grouped in the mediocre middle. And what's more, we're discovering that there is a bell curve for costs with a wide gap between the best and the worst results. And what's fascinating and important is the two curves do not match. The places that get the very best results are not the places that cost the most. They are often, like Patty Gabo's work, showing us that they're among the least expensive on the curve. And to me, what that means is that there is hope. Because if we can learn from what the positive deviants do, we can bring them into our systems of care, the way Paul is showing that we are capable of doing in 4,000 places across the country. This is the opportunity. It hangs by a thread. We have the hope of coverage, without which we cannot save lives, if people cannot even make it into the system. We have the hope of changing the way we reward people, so that we're now rewarding doctors not for transactions, but for results. We're starting to create the systems, and an organization like NCQA helps us see the metrics that lets us understand that under conditions of complexity, no one of us in medicine really have a glimpse of what the results are at the end of the day. And their metrics help us see where we failed. But we've struggled for the reality that there's a fourth component, which is that the culture of medicine and of healthcare needs to change. Len referred to the herding of cowboys. And what we've valued since the era of Lewis Thomas was the idea that the physician was self-sufficient, independent, to be left alone. But under conditions of complexity, the average person has more than one doctor. My mother, just this week, was discharged after a total knee replacement, a redo operation, complicated, and they did a wonderful job. But I counted 19 different physicians during her 3-day stay that wrote orders for her, 63 different clinicians who ended up being part of the care and actually touching her. And the number who actually talked to one another, it was shocking. It's cowboys that we have. We've rewarded, trained, and hired cowboys, but it's pit crews that we need. And we're struggling with that change. What you have with the people before me are those who have woken us up to this reality. I actually had a chance to meet a cowboy recently. And I asked him, I said, how do you actually do your job, herding all of these cattle, hundreds of cattle, traveling over miles and miles of terrain? How do you actually get the job done? And he said, well, there's actually several cowboys, and we each have individual positions, and we communicate constantly by electronic means. We have protocols and checklists. We have the systems in place for how you handle the sick cow, what you do in bad weather, the requirements for your inoculations. Even the cowboys are pit crews now. It may be time for us to join them. Thank you.